Now let's talk about your nursing assessment of the client with CHF. Think through it with me. Vital signs and lung sounds, CVP and hemodynamic readings, serum electrolytes, hematocrit. You'll track intake and output, daily weight and edema, and of course, level of consciousness and anxiety. Your nursing diagnoses will vary with the severity of symptoms. A client who has chronic CHF that is responding well to treatment may lead a relatively normal life. On the other hand, a client in acute CHF may have life-threatening complications. What diagnoses might apply? Decreased cardiac output, activity intolerance, excess fluid volume, impaired gas exchange, acute confusion, and anxiety. Your teaching will play a key role because many of these clients will have deficient knowledge of CHF. There's an old adage that goes, never present a problem without a possible solution. So for every nursing diagnosis, let's discuss nursing interventions. To improve cardiac output, administer inotropics and vasodilators as prescribed. Before each dose of an inotropic agent, assess the client's heart rate and rhythm for 1 full minute. If the rate is less than 60 or new dysrhythmias are present, withhold the drug and notify the physician. Monitor for dysrhythmias and treat them as ordered. For activity intolerance, limit activity and stimulation. Encourage regular periods of rest. You may find that bed or chair rest is appropriate for your client, but be sure to explain the need for the rest of the family and visitors. When activity restrictions are lifted, monitor the client's tolerance. Since excess fluid volume increases the workload of the heart, it impairs gas exchange in the lungs and causes peripheral edema. Interventions include elevating the head of the bed, limiting activity, and administering oxygen to decrease the client's symptoms. Be sure to use a low flow rate if the client has COPD. Remember that some clients who have COPD rely on hypoxemia to stimulate respirations, a state called hypoxic drive. If they are given oxygen at a high rate, they might stop breathing. You'll also administer diuretics as prescribed. Intake and output and daily weights help you evaluate the results of diuretic therapy. Review serum electrolytes and assess for muscle weakness reflective of hypokalemia. Remember that hypokalemia increases the risk of digitalis toxicity. Your teaching for this client and his family will include how sodium restriction will help eliminate excess fluid. Always protect edematous extremities from trauma. Edematous tissue is easily harmed and slow to heal. Make sure your client wears shoes when out of bed. Confusion is common in clients who have hypoxemia because of the decreased oxygen supply to the brain. Frequently orient and reassure the confused client. If possible, permit a family member who has a calming effect to stay with the client. The confusion should resolve when oxygenation improves. Dyspnea, orthopnea, and other symptoms of congestive heart failure create anxiety. Relieving the symptoms is the most important intervention, but you must also be calm, patient, and reassuring. Clients who have chronic congestive heart failure can be treated at home. It is especially important for you to know what resources and assistance the client will have at home. The environment should be evaluated and modified to make activity easier and safer. Key teaching points for your client and family include taking medications exactly as prescribed. If a dose is missed, the client should not double up. Advise him to get on the scale daily and to notify the physician if he gains 2 or more pounds in a week. Make sure he knows that he must report increasing edema or shortness of breath. Caution him to decrease sodium and salt intake for less fluid retention and encourage him to increase activities gradually. If he feels tired or short of breath, he should rest before continuing.
Be sure to include in your teaching that the client should not use aspirin or other NSAIDs, such as ibuprofen, because they promote fluid retention. He should consult with the pharmacist or physician about other drugs.
Now let's review what we know about thrombophlebitis. Thrombophlebitis is an inflammation of a vein that results in clot formation within the lumen of the vein. It most commonly develops in the legs, in either the superficial or the deep veins. Thrombus formation in the deep femoral, popliteal, and small calf veins is called deep vein thrombosis, or DVT. It is especially dangerous because of its associated risk of pulmonary embolism. Venous thrombi form when at least 2 of 3 conditions, called Virchow's triad, are met. They are stasis of blood, damage to the wall of the vein, and hypercoagulability. What are some of the risk factors for thrombophlebitis? Bed rest or any prolonged sitting that decreases circulation. In the military, they see it in soldiers confined to a tank, or you may see it in clients who take long plane rides. Immobilization after trauma, leg, hip, or pelvic injury or surgery, obesity, malignancy, pregnancy and delivery, oral contraceptives, cigarette smoking, and dehydration. Prevention of thrombophlebitis focuses on preventing venous stasis, venous trauma, and hypercoagulability. For clients who are at risk for thrombophlebitis, active exercise, position changes, good hydration, and compression stockings or intermittent compression may be helpful. After surgery or trauma, the client should be assisted or encouraged to ambulate as soon as permitted. Weight loss, if needed, and increased activity reduce the risk of venous stasis. People with other risk factors, particularly those taking oral contraceptives, should be advised not to smoke, as this compounds their risk. Subcutaneous low-dose heparin is prescribed prophylactically for some high-risk clients, such as those having orthopedic surgery. Other drugs might be used for this purpose include low molecular weight heparin, trade name Lovenox, Dextran, a plasma expander. Dextran works by making cells slippery so that they don't stick together. Warfarin, trade name Coumadin, and aspirin. Clients who have thrombophlebitis might or might not have signs and symptoms. Common findings with superficial thrombophlebitis are localized warmth, redness, tenderness, and pain. When palpated, the superficial vein may feel like a firm cord. This is called induration. Manifestations of DVT include venous distension, edema, pain, and tenderness when pressure is applied over the affected area. The muscle over the area may feel hard. Venous congestion might turn the skin a deep reddish color. The value of time-honored tradition of assessing Hohmann sign is debatable. Some sources recommend it as part of routine assessment, whereas others caution that it is nonspecific and unreliable. Hohmann sign is pain experienced in the leg when the foot is sharply dorsiflexed while the knee is bent. It might be an indicator of thrombophlebitis. The preferred diagnostic procedure is duplex ultrasonographic scanning. Doppler blood flow studies can also be informative. The key elements in the treatment of thrombophlebitis are rest to prevent mobilization, drug therapy, and measures to prevent the formation of new thrombi or extension or embolization of existing thrombi. Superficial thrombophlebitis, such as that caused by venipuncture, is treated with elevation, heat, NSAIDs, and compression hose. Anticoagulants are not routinely used because the risk of pulmonary embolism from superficial thrombophlebitis is low. Anticoagulation is indicated for DVT, however, because of the risk of pulmonary embolism. There are several options. Unfractionated heparin is given intravenously or subcutaneously to prevent new thrombi and extension and embolization of existing thrombi. Baseline coagulation studies are done, and PTT is monitored throughout therapy. Platelets might be suppressed, so they should also be monitored at intervals. The target PTT is 1.5 to 2 times the normal control. Protamine sulfate is the antidote to be given when clotting times are too prolonged. Low molecular weight heparins are only given subcutaneously. They can be given on a fixed schedule and do not require close PTT monitoring, which makes them safe for home use. An example is enoxaparin, trade name Lovenox.